Hey, everybody. My name's Lynn, and I work with the Prosper Health Coverage Program at Foundation Communities in Travis County in Central Texas. And we are so grateful and excited to partner with the Breast Cancer Resource Center to present Health Insurance, a Guide to the Basics here today. And what this program or what this video is going to do is just going to provide some basic terminology connected to different types of health insurance that many folks have. There are many more complicated issues connected to health insurance that we'll have other videos about. This one is just kind of like a 101 introduction to basic terminology so that folks can make sure that they have the kind of like foundation levels of understanding connected to health insurance. So this is Health Insurance, a Guide to the Basics. Thanks everybody for being here. So what we'll talk about today are some, like I said, basic terms. By the end of this presentation, you'll know what health insurance is versus types of coverage that are not health insurance and that should not call themselves health insurance. We'll talk about cost sharing, which are the shared costs between health insurance companies and individual people to make healthcare affordable. Premiums, the monthly payments people make into their health insurance companies so that they have access to their plans. Deductibles, the chunks of money that people have to pay in order to activate their health insurance plans, their health insurance plans, cost sharing with them. Co-pays, amounts that people can pay before they have to meet their deductible, out-of-pocket maximums, amounts that if people meet their out-of-pocket maximum by paying out-of-pocket for their own co-pays and cost-sharing amounts throughout the year, then the health insurance company has to cover them afterwards, and then health insurance navigators also, like me and like my coworkers here at Foundation Communities in our Prosper Health Coverage Program. So what we've got here is a slide that just has some of our more common eligibility-based public programs. So the next slide, we'll talk about employer coverage. We'll look at individual coverage through the health insurance marketplace, but a lot of people do have health insurance through Medicare, Medicaid, or the Children's Health Insurance Plan. These programs are generally determined, like people's access to these programs is generally determined by their age or their disability status and or their household incomes. So in order for somebody to get into Medicare, they generally have to be over 65 years old, have worked in the United States and paid taxes for long enough, Medicare taxes long enough for them to qualify for Medicare, or they have to have a qualifying disability. For Medicaid, people generally have to be under 18 years old, their family household incomes have to be limited, or they have to be a member of a disability population also that qualifies them for Medicaid. And then a little bit, with a little bit more flexibility as far as income goes, there is the Children's Health Insurance Plan also. CHIP, or the Children's Health Insurance Plan, operates a lot like Medicaid, but it has a higher income threshold for families who might have a little bit more income. Medicaid, there tends to be no monthly premium for plans that people get into through Medicaid, versus for CHIP, or the Children's Health Insurance Program, people do tend to have to pay a modest premium to have access to those health insurance plans. So importantly, all three of these programs, Medicare, Medicaid, and CHIP, in most cases, not in all cases, but generally, people pay either a little bit or none at all, but it is public programs, public funds of money that help people pay for private health insurance companies. So if people get into Medicaid, depending on where they are, they'll pick a private health insurance company and Medicaid funding will help them pay for it. Same with Medicare, same with the Children's Health Insurance Plan. And again, I'm speaking very generally here. So there are lots of other circumstances connected to these kinds of programs, but in general, people get into private health insurance plans and these programs help them pay for those plans. Importantly, there are lots of different kinds of Medicaid. There is one type of Medicaid for children who are under 1 year old. There's another type of Medicaid for kids who are 1 to 18. There's a Medicaid for pregnant people. There's Medicaid, like I mentioned, for people who have disabilities. And there is also Medicaid for people who have breast or cervical cancer. So that type of Medicaid does have a different application than traditional Medicaid types, like those for people who are pregnant or for people who are young. So if you are interested in seeing if you qualify for Medicaid for people with breast or cervical cancer, do reach out to the Breast Cancer Resource Center. They are one of our offices who can help point people in the right directions and make sure that they get the application help that they need to fill out the Medicaid for breast and cervical cancer program. And one more note before we switch away from this slide, Medicare and Medicaid are very similar words. It's kind of frustrating sometimes how similar those words are. A little trick that we use in our program to make sure that people know which kind of coverage they're talking about. Generally, people who are over 65 tend to be retired more so than people who are younger. And so since older folks might be retired, the word starts with an R, and Medicare has this R in it right here. That's how we oftentimes use the memory trick to help us remember which kind of program we're talking about. So Medicare for older folks, generally. Medicaid for younger folks, generally. Older folks may be retired, and Medicare both have R's in them. So in case that's helpful to anybody moving forward. All right, now we'll move on from here. So main types of qualified health insurance are the following: employer health insurance, those 2 or 3 public programs that we just talked about, Medicare, Medicaid, and the Children's Health Insurance Plan, and then also coverage through the health insurance marketplace. So importantly is this term here, qualified. And we'll get a little bit more into that later, but these are the 3 types of coverage that tend to be the ones that will give people access to qualified health plans, which means that they are good and affordable coverage plans that will help people cover the things that they need medically. So you can see here in this list of employee benefits and perks, health insurance is listed here on the top right of that picture. Most people in the United States who have health insurance from employers. The numbers are about like 47% or so. So not quite a majority, but a much bigger chunk of people who have qualified health plans have those health plans through an employer. But if somebody might qualify for more affordable coverage through a public program, or if somebody maybe doesn't have an employer that offers them health insurance, or maybe they're just not working right now, maybe they're self-employed, those folks tend to have coverage through the health insurance marketplace. So these are like our 3 main categories of qualified health plans here. And if people do transition out of a certain job, or maybe they had a spouse who quit or left their job, then those people can oftentimes qualify for COBRA. COBRA stands for the Consolidated Omnibus Reconciliation Act of 1985. The way that I remember that is COBRA starts with COB, and we tend to think about COBRA in terms of it's allowing people to have a continuation of benefits of coverage that they had through their employer. So once people no longer have access to their health insurance plan through their employer, they can generally extend that plan for 18 months or 36 months in some circumstances, but usually 18 months. The tricky part about that continuation of benefits is that employers are no longer required to share monthly premium costs with individuals. So if a health insurance plan costs $400 and an employer is helping somebody pay for it with, $300 per month, then the employer pays $300 and the employee pays $100. Now, if somebody gets on COBRA, though, then they have exactly the same plan. Maybe they want to make sure that their medications are covered, or maybe they're in the middle of a treatment, or they're planning a surgery with a doctor who's on that employer plan. And it would be most helpful for them to stay with those doctors and not have any kind of clunky health transition afterwards. If that's true, then somebody might opt for COBRA, even if their employer is no longer helping them pay for the monthly premium. So, but like I mentioned, it's really cool when employers will do that, but it doesn't happen all the time. So for some people, if they lose that $300 or so that the employer is paying, and they're on the hook for $400 per month, then for those folks, sometimes it is more effective for them to go straight from the employer plan over to the marketplace, or in some cases also, depending on eligibility, straight over to a plan like Medicare or Medicaid. So COBRA is a really important policy. It does give people access to continuity of care after they leave their employers. But for some people, a transition immediately after employer coverage is over as soon as they lose that job is necessary, because employers are no longer required to share those monthly premium costs with people. And like I mentioned, there are lots of non-qualified plans out there. So if you don't have Medicare, Medicaid, a marketplace health insurance plan, CHIP, or an employer plan, then oftentimes what some folks will do is they'll go to the internet and they'll say, help me find health insurance. And they'll end up on one of these websites or dozens of other websites that tend to draw people into more affordable plans, but more affordable plans that don't have the same kind of coverage that qualified health plans have. So what happens in our office is sometimes people will come in and they'll say like, yeah, I have this health insurance plan, but I went to the emergency room and the health insurance plan isn't helping me pay for it. Or I developed asthma this year, and all of a sudden I'm learning that my health insurance plan doesn't cover inhalers. What do I do? And oftentimes what we learn from those folks is that they are on a non-qualified plan, which means that they are not protected by health laws that protect people who get qualified plans. So those health laws say things like doctors have to cover health insurance plans have to help people pay for all medically necessary things, whatever that medically necessary thing is. But these limited benefits plans, these short-term plans, these catastrophic care plans, they are not governed by laws that say you have to do this if people need certain kinds of healthcare. So we are available to check out what plans people have, to help them learn about those plans and see what their options are if people are on non-qualified health plans. But it's just really, really important for folks to know that oftentimes these plans will not cover all the things that people need. And so important then to make sure you know who your local health program navigators are, so that you're not just talking with agents and brokers. And some agents and brokers are awesome, but agents and brokers get paid by the health insurance companies into which they enroll people. So there's an incentive relationship there for the agent and brokers to enroll people into the non-qualified plans, or sometimes into the qualified plans that they have relationships with, but they won't tell people about all the other qualified plans that are out there. So important for folks to know that if you're working with agents or brokers, those folks do have incentives for them to get people into certain plans versus health insurance navigators. Because we are federally, locally, or state funded, we have to give people unbiased advice and have to give people a complete picture of the health programs that are out there for them. Now, healthcare in general is expensive, right? Doctors go to school for a long time. The equipment that people use to assess their health conditions is expensive. So healthcare itself is expensive. Health insurance helps make it affordable. And the basic term here for health insurance is cost sharing. Very generally, cost sharing is the practice of sharing costs. One part of the cost goes to the health insurance company. One part of the cost goes to the insured person. So cost sharing is the real basis, of the real foundation of making health insurance affordable to people. We'll go over these terms here: deductible, out-of-pocket maximum, copays, and coinsurance. We will do a presentation also with the Breast Cancer Resource Center about provider networks. We'll skip that one for today just because we'll cover the basic cost sharing terms. But importantly, any questions about provider networks, give us a call. If you're not in Texas, we'll connect you with somebody in your state who can help with you, or who can work with you. And so importantly, monthly premiums. Monthly premiums are the kind of access fee that gives us access to our health insurance plan. So the cost sharing relationship that people have with their health insurance companies is oftentimes based on their premiums. So people who pay higher monthly premiums tend to have lower deductibles, lower copays, lower coinsurance, and lower out-of-pocket maximums. So what that means is that the health insurance company is paying more for their cost sharing responsibilities. So the higher premium means that the individual has lower cost sharing. And the inverse is also true. So if people have lower monthly premiums, then they will have higher cost sharing, which means their deductible will be higher oftentimes. Their out-of-pocket maximum will be higher oftentimes. Now, that's not true 100% of the time, but just in general, if an individual is willing to pay more per month with their monthly premium for a health insurance plan, then the health insurance company is willing to pay more per month for that person's healthcare. So for the direct cost of their healthcare, when they see the doctor, when they need MRIs, when they need x-rays. So just for a quick example, for somebody who has a higher monthly premium, they might have a $20 copay to see a doctor because they're paying more into the plan per month. For somebody with a lower monthly premium, maybe somebody pays just $10 per month for their plan, they tend to have a higher copay to see the doctor. So maybe $50 or $100 per month, per visit with the doctor. So it really just depends on what the contract looks like for each individual health plan. And there are many contracts out there, and there's no way to really get into we have some examples at the end of these slides, but there's no way to do an assessment of like all health plans. So those basic principles are very, very, very generally true. So The more an individual will pay per month, the more the health insurance company will help them pay for things like doctor's visits, medications, and treatments throughout the course of the year. And importantly also, a health insurance premium is not debt, right? A health insurance premium is an access fee, kind of like a gym membership. If you want to go to the gym, you got to pay your membership fee. For the health insurance plan, if you want access to that health insurance, you got to pay your monthly premium. Sometimes people, if they switch plans from one to another, like, I don't know, maybe they were on an employer plan and they switched over to the marketplace or maybe to Medicare or something, the health insurance company will continue sending them a premium statement because the health insurance company just, they want to get paid, right? So and the health insurance company, unless you actively cancel your plan, they might not know that you've switched over to Medicaid or Medicare. Or a marketplace health insurance plan. So if you do get a premium statement for a health insurance company that you no longer need or that you no longer have access to from an employer because the employer is not helping you pay for it anymore, don't pay it because you think it's medical debt, that monthly premium statement. Just go ahead and call your employer, call your health insurance company, call your local navigator and say, hey, here's what I've got. I just want to make sure that I don't have to pay this premium statement. And the answer in general will be no. That is an access fee. It is not debt. Now, bills from doctors are another things, right? Bills from health insurance company are another things, but those premium statements are access fees, not medical debt. So you do not have to pay them unless you want or need access to your health insurance plan. Now, here we have some of the more structural or more plan specific costs that connected to cost sharing. So a deductible, and like I said, there will be some visuals after this presentation. So if reading words is not being super helpful, then just hang tight and we'll get to the examples here at the end. So a deductible is like a chunk of money that an insured person has to put into their health insurance plan, or they have to reach that amount by going to doctors before the health insurance company will help them start paying for things. So if somebody goes to their doctor and the doctor says, oh my gosh, that ankle sprain looks really bad, let's get you an x-ray. And that x-ray costs $2,000. If somebody has a $3,000 deductible, you're going to drop that $2,000 cost for the x-ray before the health insurance company is going to help you start paying for it. Because the deductible amount is the amount that the covered person must pay before the health insurance company will help them start sharing costs or will help them start paying for things. So the deductible is a really important amount. Now, copays do exist on many plans, not on all plans, but many plans will have copays that give people cost sharing support from the health insurance company before they meet their deductible. So the incentive here is really, I mean, it's for the insured person, but it's also for the health insurance company. Insurance companies know that conditions tend to get more expensive as they get down the road, as they develop or get worse, if people don't see the doctor initially. So say somebody has that sprained ankle and they don't have a copay to see a doctor, so they just keep walking on it, maybe they keep driving on it, and then down the road it becomes a stress fracture rather than a sprained ankle, and then somebody has to be in a cast and the health insurance company has to pay, I don't know, maybe thousands of dollars for a surgery. The individual still has to meet their cost sharing amounts, but the insurance company recognizes that they also will have to pay more down the road if they don't throw people a little bone and give them access to doctors for affordable costs before people meet their deductible. So oftentimes copays will apply to medications and doctor's visits, although sometimes you will find health insurance plans that have copays also for maybe blood tests or imaging like x-rays or MRIs, but all of those specifics, they just depend on the health insurance contract that people buy into when they pick their plans. So again, work with your employer's HR office, call your local health insurance navigator, whatever kind of support you need to make sure that you're picking a plan that makes you feel comfortable as far as the monthly cost and the risk that you take on, whether you get into a plan that has copays or not. Just make sure that you know what you're getting into, and your local health insurance navigator and or your employer's benefits department can help you figure that out. So copays, the fees that people pay that will give them access to doctor's visits or medications usually before they have to meet their deductible. So if somebody needs to go see a general practitioner because they have a sore throat, generally a doctor's office will charge maybe $150 or $200 for that visit. If somebody has a $10 copay set up with their health insurance company, they pay $10 and the insurance company pays $140. And then that person goes to at least have a conversation with the doctor before they have to meet their deductible. Okay, coinsurance. Now, after somebody meets their deductible, say their deductible is $2,000 and they needed a $5,000 x-ray. You drop $2,000, you meet the original deductible, and then there's $3,000 left of the cost of that x-ray. So that's when coinsurance kind of like activates or kicks in. So coinsurance, the percentage split between an insured person, their health insurance company, and the percentage split is based on the contract. So some health insurance companies will offer people 20% coinsurance, which means the individual pays 20% of the cost of their healthcare and the health insurance company pays 80%. Maybe it's 40% to the covered person, 60% for the health insurance company. Generally, if somebody gets into one of those 40-60 splits, they'll have a lower monthly premium because the health insurance company helps them pay for less in the day-to-day or the month-to-month. All of these costs, as we're breaking them down here, will be lined up or laid out in somebody's summary of benefits and coverage. We're not going to cover that today in this presentation. There will be another presentation down the road that will cover those and things like provider networks, like I mentioned earlier. But for this purpose, for today, coinsurance is the percentage split that the health insurance company will help people pay for their healthcare after they meet their deductible. And then lastly here, the out-of-pocket maximum. This is super important. And the out-of-pocket maximum is often what is lacking if people get into one of those non-qualified plans that we talked about earlier. So the out-of-pocket maximum is the maximum out-of-pocket cost that an individual covered person will have to pay over the course of a coverage year for their healthcare. So if somebody had that sprained ankle and they paid their $2,000 deductible for their x-ray, and then it turns out, oh my gosh, you need a surgery and you need some plates put into that ankle because it's actually broken, or whatever the unfortunate scenario is, better to get the healthcare to be as healthy as possible moving forward than to not get it and risk having complications or more expensive care down the road. So say that person needs more expensive healthcare after they get those initial tests, after they see that initial doctor, and maybe their coinsurance split is, maybe it's 80-20. But if a surgery costs $10,000 and a person is paying 20% of that, that's still a $2,000 cost. So if somebody's out-of-pocket maximum is $2,000 or $3,000, then as soon as they incur the medical debt that reaches that out-of-pocket maximum, they can set up a they can set up a payment plan with their surgeon or with their doctor's office. But as soon as the bills that people get reach their out-of-pocket maximum, whether it's $2,000, whether it's $6,000, whether it's $9,000, whatever the out-of-pocket maximum is, the health insurance company, as long as it's a qualified health plan, has to cover that individual's health care for the rest of the year completely at 100% cost sharing. So 100% cost sharing means that health insurance company is covering 100% of that person's medical care for the rest of the coverage year. And then when the new coverage year starts, the amount starts over. So you go back to zero. But the out-of-pocket maximum is the real cornerstone of health insurance, because some surgeries, if people have an accident and they end up in the hospital, like if you're in the hospital for a week, you're looking at hundreds of thousands of dollars of medical debt. And if somebody has an $8,000 out-of-pocket maximum and they're in a hospital that their health insurance company will help them pay for, then the health insurance company is paying for all of those hundreds of thousands of dollars after the $8,000 out-of-pocket maximum. So this is the real debt avoidance strategy of having health insurance. This is the real financial protection that not only helps people be healthy, because it gives them access to medical care, but it also helps people remain financially stable. And medical debt is the leading cause of bankruptcy in the United States. So it helps whole families maintain their financial security if individuals have health insurance, and especially have qualified health plans that give them access to a regulated out-of-pocket maximum. So to an out-of-pocket maximum that meets health laws and that doesn't charge people too much for even those major medical events. And then they're covered 100% for the rest of the year. So let me get out of here and we'll move on. And now we're just going to look at some examples, like I mentioned earlier. So here we have an individual named Izzy. Izzy is employed by an imaginary company that I made up, the Texas Society of Reporters. Their employer health insurance is another imaginary company, the home run insurance company. The monthly premium for the plan is $450. The employer pays $400 per month. So Izzy's monthly premium is $50. Now, importantly, monthly premiums do not contribute to out-of-pocket maximums. Only copays, deductibles, coinsurance amounts, those are the costs that contribute to out-of-pocket maximum. So this $50 per month, Izzy can plan on paying that every month that she has, that he or she has this health insurance plan. So for $50 per month, and then the health insurance company, sorry, the employer will help Izzy pay for the rest of it. So now, what happens? This health insurance plan from Home Run Insurance Company that Izzy picked when Izzy signed on to the health plan that they chose from their employer's enrollment period. Izzy pays $50 per month. Deductible is $1,000. Out-of-pocket maximum is $4,000. We've got $20 copays to see primary care doctors, $50 copays to see specialist doctors. And again, we'll talk more about those types of doctors in a different video. We've got copays for tier 1 medications, copays for medications that might be a little bit more expensive, coinsurance after deductible for imaging, and then coinsurance also for lab services like blood work after deductible. So for lab services and imaging, Izzy does have to meet this $1,000 deductible before the health insurance plan will help Izzy start paying for any of those things. But we've got copays set up for primary care, specialist care, tier 1 medications, but then we have a coinsurance for tier 3 medications. So if somebody needs an expensive asthma inhaler that's at tier 3 in their health insurance company, the health insurance company is going to pay for 90% of it. Izzy pays for 10%, but only after Izzy meets that deductible, because this is a coinsurance amount, not a copay amount. So here's just a scenario. Izzy starts feeling fatigue. It lasts a little while, makes an appointment with the primary care doctor. Cost of the visit, $200, but we know that Izzy has a $20 copay for primary care doctors. So here, the health insurance company pays $180, Izzy pays $20. And then after that initial visit, during that visit, the primary care doctor suspects a thyroid issue, prescribes a blood test. So the blood test does not happen in that office. It's not part of the office visit, right? The blood gets drawn, but it has to go to a lab. And we know from that breakdown earlier that labs like blood work for Izzy has a 30% coinsurance. So that means with the coinsurance, Izzy has to meet that $1,000 deductible before the health insurance company will help Izzy start paying for it. So if the blood test costs $300, then we know Izzy's going to pay for the full amount because $300 is less than $1,000. So the insurance company is paying nothing before Izzy reaches that deductible. But now, moving on, the primary care doctor calls Izzy and says, we got nothing from the blood test. We didn't learn very much. We need to schedule you an MRI on your thyroid and see what's going on. So the cost of the thyroid MRI is $1,500. And I pulled these numbers. I made these up completely. So MRIs oftentimes cost much more than that. But just for this example, $1,500 for the cost of the MRI. And since Izzy has already met some of that deductible, right? How much does Izzy pay? So here we've got some equations. So Izzy already paid $20 for the primary care doctor visit, but copays do not count towards deductible. So we've got $300 paid for the blood test. So we've got $700 left to go on the deductible. The MRI costs $1,500, but we subtract the $700. So there's $800 left on this MRI that Izzy needs. So out of that $800 left, we know that there's a 30% coinsurance on imaging, right? You can see that listed up here again. So that's for Izzy, 30% of $800 is $240. So rather than paying another $1,000 deductible for that MRI, you only have to meet the deductible once in the year. And so for Izzy, it's $240 for that MRI after the extra $700 towards the deductible, right? And then after the $300 for the blood test on the other visit. So total, the cost is $940 for Izzy from that $1,500 MRI. So, but now Izzy has met the deductible for the rest of the year, and the insurance company now pays $560 for that MRI, and then afterwards 70% of all other blood work, all other imaging and whatnot afterwards. And then for Izzy, because their out-of-pocket maximum is $4,000, they have already paid $1,000 for the deductible, $20 for the primary care doctor visit, and then also this amount here, which would be, let's see, $240 post-deductible. So Izzy has paid $1,240 and actually $1,260. So that's $1,260 towards the out-of-pocket maximum. So Izzy's got just over, $2,700 to go before they meet their out-of-pocket maximum for the year. Now, hopefully that would never happen. Hopefully people don't meet their out-of-pocket maximums. If they do, the insurance company has to cover them 100% for the rest of the year. But if they don't, then that's good. Then that means that they didn't need any more medical care after that MRI. Maybe they sorted out the thyroid problem with the medication after they looked at the tests, the results of the MRI, right? But if Izzy does ever meet that out-of-pocket maximum, then the health insurance company has to cover everything for the rest of the year, as long as Izzy is still seeing doctors who are in the provider directory for the plan and is still paying that monthly premium, that $50 per month. So here is a visual. We've got the deductible that an individual must meet, right? And then after somebody has met the deductible for the year, then we've got the health insurance company and the individual paying for the rest of those services up to their out-of-pocket maximum. And again, the out-of-pocket maximum is contracted by the insurance company, depending on what plan people get into. And then for Izzy, again, like just in the example of this person, that deductible is $1,000 and that out-of-pocket maximum is $4,000. So those two figures here will vary based on what plan, based on what company, based on what level somebody chose. But in general, this is how the cost sharing split works in a visual way. And it is really helpful. Like, we have tools that we can share with people to help them track their medical costs, to make sure they know like when they're after the deductible stage, once they're in the co-insurance stage, or how close they are to their out-of-pocket maximum. But those are really individual conversations. They just depend so much on the types of plans that people got when they were signing on through their employer or through the health insurance marketplace or wherever they get their qualified health plans from. As a navigator organization, Foundation Communities has helped over 47,000 Texans enroll in and use qualified and affordable health plans since 2013. We do help people across the state of Texas. Our certifications are state-based. And so if there are people watching this video who are not living in Texas, you can still contact us. We can connect you with navigator organizations that are outside of our state. We're part of many national coalitions to help make sure that we're all working together so that people can have access to affordable healthcare. We are certified by the Federal Centers for Medicare and Medicaid Services, and our navigator certification does mean that we get funded by those offices to help people find affordable healthcare. And we'll talk a little bit more moving forward about why using an organization that is funded by the federal government is oftentimes more effective than using organizations or people for healthcare advice who are funded by health insurance companies. We do partner with hospital districts, public health offices, school districts, community-based organizations like the Breast Cancer Resource Center to help make sure that as many people as possible know what kinds of health coverage programs or health insurance are available to them, how they can get into those programs, and then also how to use them, very importantly, afterwards. So our contact information is at the bottom of the slide. Like I mentioned, we are only certified to work directly with people to help them find health programs in Texas. But if anybody watching this video is outside of Texas, no worries, give us a call. We can connect you with one of our dozens of other partners around the United States who do work in individual states and who can work directly with you also. Again, our contact info is down here at the bottom. Please feel free to reach out to us. Thank you so much again to the Breast Cancer Resource Center. We're so happy for your guidance and for your support of all of our Central Texas community members connected to their breast cancer and cervical cancer diagnoses. And thank you everyone for watching this video, and don't hesitate to reach out to us again. We are the Prosper Health Coverage Program at Foundation Communities, and we look forward to speaking with you soon.